Hello and welcome. My name is Jane Ngivu, the Manager for Quality Improvement, MP Shah Hospital, Nairobi, Kenya. I'll be sharing with you one of the quality improvement projects we've been able to effectively roll it out within the hospital so that you can be able to understand and see the success stories we've been able to have on this particular aspect. And what I'll be sharing with you is our improvement process, especially around handing over process. The aim of this project was improving handing over communication within the hospital, and this is an IPSG which we've actually been working on. In terms of background, handing over is very key in healthcare. There are so many gaps and errors which affect patient care, and one of the key things which has been noted is that handing over is one of the very problematic areas which many healthcare organizations usually face. So as a hospital, as part of our international patient safety goals implementation, we decided to put strong emphasis on improving handing over process, and we were able to roll out one of these projects. Problem statement. I think for us, one of the things we realized when we were starting this project is that we did not have quite a lot of standardized templates for our teams to use. We had something for use in our nursing departments, however, it needed some refinement, and also it required to be rolled out across the other teams. The other thing we noted also as part of our problem was that our policy required to be relooked into, aligned, and in terms of what best practice requires of us to be able to roll in place for purposes of effective handing over process. So that's one of the areas we really focused on, improving the tools and also the compliance process. The other thing we noted, especially at the start of the year 2022, January, February, we had the highest number of handing over related incidents, which was 4 in January, 3 in February, making a total of 4 incidents within a very short duration of only 2 months. According to us, this is a high number, and we had to put a big focus so that we can be able to eliminate this, because for us, at least for international patient safety goals, our target is that we are committed to making sure we are able to improve our compliance and consequently reduce our incidents to almost 0. Now, the methods we used, there are some things we needed to roll out in terms of change ideas, change initiatives. So we rolled out quite a number of change initiatives. And to start with, one of the things we started with was working on our policies and procedures. I mentioned that this was an area we realized needed to be refined. One of the standards we are currently focusing and looking at is the JCI standard. Of course, also looking at what are the best standards require of us. So we refined our tools and we were able to align our policy to make sure we have a streamlined handing over process for all our clinical teams. And here, the stakeholders we keenly involved were our doctors, our nurses, and then we also extended the same to our laboratory and our radiology departments. The other area we also incorporated in this particular process, after streamlining this particular tool, it was important that we carry out education of our staff. So one of the key improvement actions we rolled out was making sure we have an induction process, and we ensured that for all our new nurses, our new staff induction process, we incorporated the international patient safety goals, we incorporated handing over process in this particular induction process. So once our new nurses or our new clinical teams come, one of the induction things we take them through is our handing over tools. And this ensured that we are able to see how we can incorporate them into the system so that we can be able to implement and work closely together on this particular aspect. And still talking of the training, the other bit we also rolled out was apart from the standardized tools, which we were able to refine and make sure for the nursing tools, we were able to look through them and make sure we have very good tools which will address nursing handing over at the various stages, which is shift after shift handing over. We have tools which address handing over from one department to another, especially for our nurses. For our doctors, we were also able to come up with handing over tools, which they are also using for this particular process. Another aspect in terms of our tool standardization was even for our other clinical teams, our radiology teams, our laboratory teams, we have standardized tools. So this was a good beginning for us, just making sure we have the right tools in place so that our staff can be able to roll out the right tools to support the handing over process. Still on the same, another very key important change idea which we were able to roll out was on staff training. I know it's one thing to have tools, it's one thing to have policies and procedures, but so long as our staff do not know how to use these tools, do not know what the policy requires of them, do not know the importance, it becomes quite difficult for us to gain any improvement. So one of the things we ensured we rolled out was staff training. And the approach we used was face-to-face trainings where we had CMAs in organized forums, CMAs within the departments just to take the team through their tools. And the other bit still on the same was to make sure at least we also have trainings, virtual trainings, especially for staff who were not able to meet on a face-to-face. And the other bit was also to make sure we have, to reach a big number, we rolled out virtual training forum, which is self-paced. And what we are using currently is Google Classroom, whereby we are able to put the policies there, to put the tools there, and also to put recordings, training recordings there, so that whoever is not able to attend the face-to-face, then they are able to follow the trainings at a safe-paced approach. Talking of the improvements again, the other bit which was also key for us was we rolled out audits. It's important that we monitor the process. So we ensured we have an auditing process where we are able to look at compliance of the tools, compliance of the handing over, the actual handing over process. And also the other bit we are looking at the tools is incidents reporting. This is one of the other data we are capturing. Every month we collect data around incidents, around handing over process. We are able to analyze and tabulate this data month by month. And one of the things with the audits, both for the compliance and also for the incidents, which we usually do, is to make sure we give feedback. Feedback is very key so that our departments, our teams can know what exactly their performance is and the areas for improvement. This helps them improve. The other improvement we also rolled out in this process is to make sure we have a root cause analysis process. And this is for all the incidents. We make sure 100% of every incident which happens, we are able to carry out root cause analysis to find out with the teams. This ones we work with the teams involved, the departments, just to find out what the issues were. And we are able to come up with the improvement actions which are aligned with the gaps which we have found. And the other thing which we linked with the root cause analysis is a just culture process. And this enabled us to make sure we adjust in our approach, the way we deal and the response to incidences, so that staff, again, do not reach a stage where they start hiding incidences. So we are rolling out a just culture process. The other thing which also the hospital does is biannual campaigns, where we do it twice a year. We make sure we have a focus area where we are focusing on patient safety for a whole week. We do this in the month of March and in the month of September, just to make sure the whole hospital is brought on board around patient safety. And one of the key areas we focus on largely is International Patient Safety Goal. And in this, we also discuss handing over process. And part of this process, we also ensure we have reward and recognition process for our teams. So those are some of the improvement actions we've been able to roll out. The improvement, the methodology we've been able to use is the IHI improvement model. And how we are doing this, we are following the PDSA process. We make sure the tools, before we roll out the tools, one of the things we did was to make sure we are able to look at it. We roll it in a small scale, whereby we start with one ward, a nurse or two, just to work on the tools, roll it out, so that in case there is anything, then we are able to look at it and we are able to implement. So as part of the implementation process, we roll out our PDSA so that we are able to pilot. We look out at the things which have been found, and in case there is any requirement for change, then we are able to roll it out. So this is the process which we do. We've done a series of PDSA cycles, and at the end of it, we've been able to streamline our tools, to streamline our processes, and this is what we've been working on. So what have we been able to accomplish as a hospital? Looking at the data we have for the hospital, one of the things I mentioned was problematic for us was a high number of incidents around the handing over process. We've been able to track this month by month, and we started with 4, then 3 at the start of it each month. And as we completed in the month of June this year, we were able to see this reduce significantly to 0 by the end of June. We had reduced this to probably 1 in December, 1 in April, and we had 0 in the month of June 2023, which was a good thing. And this is despite seeing an increase in the incident reporting across the hospital. In terms of handing over communication audit process, this is another area we've been able to audit. The graph here we have here shows that we've been able to improve. I know we started at around 70, so when we started this, and we were able to continually improve over the months, and we closed at a score of 89%, which is also another good thing we've been able to see in our handing over process. Still looking at the results in terms of staff training, we've seen quite a number of our staff enrolling and being trained on in the National Patient Safety Goal, which is one of the largest numbers of attendance we'll be able to see so far. The other bit which was also good for us to look at in terms of results for this particular project was to look at our culture of safety performance. This is something we've been monitoring every year. We audit annually. We did this survey in 2021, 2022, and we just concluded the survey for 2023. So there are 4 areas we've been able to look. We're using a tool which is used by the HALC, AAHRQ, the tool for culture of safety survey. So one of the questions there under handoff and transition is a question which looks at things fall apart between cracks when transferring patients from one unit to another. Here we are looking at the staff who are strongly disagreeing or agreeing with this, and we've seen an increase on this, showing that at least the culture has improved on this. We were able to improve from a score of 53%, we closed at a score of 60 in the year 2023. Another important aspect here has been looking at one of the questions which looks at important patient care information is often lost during shift changeover. And again here, the positive is where we are looking at those who are either strongly agreeing or strongly disagreeing or disagreeing on this. And again here, it's an area we've also seen an improvement. We were able to move from 68, we closed at 74%, which is also another very good improvement for us as a hospital. The third question, still under handoffs and transition, looks at problems often occur in the exchange of information across hospital units. This is also another measure for handoff transition across the hospitals. And again, here, looking at the compliance here, looking at those who are scoring strongly disagreeing or disagreeing with this statement, we've seen a very good improvement where we started at 52%. We've seen this improve all the way to 61%. The last question on the handoffs and transition looks at shift changes are problematic for patients in this hospital. And again, this is another area where from the graph we have here shows that as a hospital, we've been able to improve on this aspect. From a score of 64%, we closed at 71%, which is also another good improvement we've been able to see within the hospital.
Just to take you through the nurses shift departmental transfer handover tool. This is a tool that was implemented way back when we had problems with the nursing handing over. So we came up with this tool that is just to aid us with the standardization of the actual content of the tool itself. So the first thing we see on the tool is the patient identification, and we as MP Shah have made out that the patient identification is the patient's full name, date of birth, and UHID number. So once that is done, then we normally what happens, we hand over with the ice bar. So this tool has taken a form of ice bar. So what we'll start is at the beginning is the background of the patient. Remember, when we admit this patient, what we want to know is the background. So we take the history. This can be related to maybe what the patient had before admission. Is it maybe patient is diabetic, how long the patient has been diabetic for, and maybe the medication the patient is taking currently. So that is noted down as the current background history of the patient. Once you're done with the background of the patient, you go to the medical history. Medical history, we look at the chief complaint, what the patient has come with now. Patient might have been a diabetic, hypertensive, but now what the patient is presenting with is different. So maybe he has come with nausea, abdominal pain. So that is what you look at, you write on the medical history. Once you're done with the medical history, we take food and drug allergy. So you have to confirm this with the patient. And outside this, there's an allergy form that a patient has to sign again. So this is also noted as there. In red, if the patient is allergic to any medication, maybe sulfur, then you note it in red and hand it over during your next shift. The next thing is the current treatment or intervention the patient is on. So remember, when you are handing over your two nurses who are handing over between each other at the same time, so this is where you confirm the medication, the treatment sheet the patient, the current medication patient is on. So here what happens, you look at the medication chart of the patient, look at whoever is now the person, the nurse who is receiving has to look at the medication chart and see has the patient gotten the medication as per the 10 rights of medication. The next thing, then we do our assessment. This is normally done if it was a patient who was there during the day. We normally prefer to write it almost at the end of the shift, because during the day the patient might change the condition. So here we do an actual assessment of the patient, and it starts with the neuro observation. So the neuro observation, this is where you look at the patient's alertness. We use the APVU. Depending on the patient, then the general condition, you give a score using the Glasgow Coma scale. That's a rate of 15/15. The next thing, we look at the respiration. Respiration, that one is actually just do the actual count at the time of shift change, the latest observations you've done. So you comment there the rate and the breathing pattern of the patient. Then we go to cardiac. Cardiac covers the heart rate. So that one is normally done by the, here we check the pulse of the patient, and it's normally done by, we use a pulse oximeter, which gives us the rate, but the nurse has to also feel for the volume of the pulse. Next, we do the gastrointestinal tract. So there we look at the bowel sounds of the patient. So is the patient having maybe loose motion? You note down. Or even the bowel sounds, are they okay? Are they matching what your currently patient is having? The next thing we do is the genitourinary. We look at the patient's output there. Is the patient passing well, voiding on demand, or the patient maybe has a catheter? There is where we also note at that time how the patient is voiding and the actual amount of urine. The next is we do the skin assessment. Here we pay attention especially to those ones who are bedridden. We look at the pressure points. Also, if a patient maybe has a dressing or an IV line, we also pay attention at this time and look at the same. So once we have done this, maybe if it was a patient in maternity, then there's a neonatal assessment also that is done for this patient at that time. Once we are done with this, then we go to our vital signs. As I had said, when you put them, you also note down that the latest vital signs, that is, if you are handing over maybe at 6 p.m., then we do it at 5:30 p.m. and we note down the vital sign. So remember, when you're doing the temperature, heart rate, SpO2 and pain scale, you should also include others that maybe was not, if it is not recorded in the patient's medical record, then any other thing. If patient is diabetic, maybe you're doing serial sugars, then you also do your blood glucose at that time. Then your input for the day, that is, if you're doing a 12-hour shift, you put your input at that time and you balance it with as per the balance at that time. So maybe during the day, patient had some abnormal investigation, you follow it through there. There's a place where you put abnormal lab tests, and you also have critical lab tests that are normally reported from the lab. This is the time to highlight and also hand over. Then we have the radiological results. So this, you talk about maybe the x-rays, the ultrasound, CT scans that have been done on the patient, so you record. And then others, the patient can have been requested an ECG. So that is also what you also note on the patient's record, this handover tool. So you also look at the invasive. When you're looking at the invasive, if the patient has an IV line, then you comment the status of the IV line at that time. And if not, then you put not applicable. You also look at the dressing and then maybe any other line. Remember, if this patient was in ICU, they'll have other lines like arterial lines. So you also note at this time, patient might be a surgical patient, maybe has an NG tube or has a portal vac, then you also note this down. I had commented about a urinary catheter. Also, you can also put it what your comments are. Is it draining well? Is it maybe draining the effluent of what is coming out of the patients? At that time, the color of the urine. So you can put others drains that are not mentioned above. Once we are done with this, then we do the recommendation. So when you're doing your recommendation, this is where now you put your plan of care. What do you want this other person who is coming in to do? So remember then, maybe if a doctor had seen when you're changing, just before you changed the shift and ordered an ultrasound, then you highlight here for that person who is coming in to follow up and have the patient done the ultrasound. So from the plan of care, then the consult, which doctors are seeing this patient. Remember, we can have started with one doctor and many others were called after. So you have to highlight the doctors who are seeing the patient at that time. Then test and treatment. What tests are there? What tests are pending? You can also highlight them there. So in MP Shah, what our plan is always on admission, we discharge our patients. So as you're admitting, there are always your daily things you can do. So we also have the discharge needs that can be done. Also, we identify maybe what are we doing for this patient? How are we helping this patient maybe change the red days to green days, which means we are helping this patient plan for home care. So this patient can maybe have a long-term home care plan. So you try and start it as early as possible. Once this is done, then the nurse who is handing over then signs off with the name, signature, and the time when she was or he was handing over to the next shift. And then the one who is receiving will also sign at the same time with the signature and her name.
As my colleague Machio has just described on how we do the handover for the nursing section, we realized that it was successful in the inpatient units, and we needed to also cascade it to the other units because the issues also would occur in the other units. So we introduced additional tools to cater for other departments. For example, in theatre, we also realized that there was a gap in communication between the scrub nurse and the PACU nurse, and tools were also added, and we added a switch handover tool where the scrub nurse would indicate the surgical procedure done. They would indicate the instructions that the surgeon had highlighted for the procedure, the timings for the procedure, and the confirmation and checks that were done. So this was done through a checklist that will be filled once the patient, the surgical procedure is done, and the receiving nurse would also indicate the same. So that was in the theatre section. Also, we realized that also our doctors required to also hand over formally, and we introduced a handover form for the doctors as well. In the field of doctors, they always communicate from the doctor attending to the patient and the one who is the consultant that has been consulted, the specialist. So you'll find that this content was not being captured appropriately, and we had to introduce standardization of this communication, and handover tool for the A&D doctors was introduced, where the accident and emergency doctor would indicate the communications done, what was done for the patient, the timings, the vital signs that were captured for the patient, the diagnosis, differential diagnosis, the investigations that were done, the communications that were already done with the specialist doctor who will continue with the care once the patient was in the wards. So this was done very well and taken up very well. Compliance was also monitored through audits. We usually do monthly audits to track how we are complying with the standardized forms and handover communication. So far so good. It has been a success, and we even want to do it better.
And basically, the essence of using a shift handover sheet is to ensure comprehensive handover and a standardized way of handing over for the nurses from one person to another, as well as the medical team. Our shift handover has shown some tremendous improvement. Basically, what we have noted is that when the nurses are preparing or writing their shift handover, they have opportunity to read through the patient's notes, review the doctor's notes, and capture the vital information in an organized manner. And this has helped us to reduce the number of missed information, for instance, investigations that were documented by the doctors in their clinical sheets. So basically, the nurse is able to pick them up and document them and hand over to the next shift, and that has reduced the number of misses. The other thing that we have noted is that it has focused the nurse in reading through the clinical notes, because for them to write the report, they have to read the clinical notes, and basically that has improved the nurse's understanding of the patient care according to what the doctor has written in the clinical notes. Something else of importance on the shift handover is that it is short, precise, to the point. So you find when the nurse has documented fully the information, it takes a shorter time to hand over than when one is reading a summary from all the patients. And the other thing is that because every nurse has to write a shift handover, it has helped them also to learn much more about their patients than before, when only one person was handing over from a summary. And that has improved the nurse's understanding of their patients. So basically what I would say, undocumented shift handover sheet is very vital in our nursing processes.
In conclusion, what we are concluding is that it's important that we are able to roll out handing over tools across the hospital. This is very key, so that we are able to effectively have standardized tools for our teams to use. The other thing is not just having the tools. Another very critical component which we are looking at is that these tools, we need to make sure we are able to train our teams appropriately so that they understand the tools and what the importance of the tools have. Looking at the recommendations for this particular improvement project, what we are recommending is standardized handing over tools needs to be incorporated in healthcare systems. It's important that we are not relying on memory for handing over. We need to have standardized tools for handing over for the various teams and cadres, tools for nurses, tools for doctors, tools for laboratory teams, tools for radiology, and all the different cadres, so that when they are handing over, it's in a standardized format. The other thing we are recommending is staff training on handing over. It's important that our teams understand why handing over is important, because so long as they don't know the why, then it becomes quite difficult for them to comply. So one, it's training on the why it's important. And secondly, it's training them on the available tools. What are the policies, what are the tools, and how are they supposed to use the tools appropriately so that they are able to do a good handing over process? And how do we involve our patients so that whatever it is we are handing over is very useful for the patient care eventually. Another thing is monitoring process. It's important that even as we roll out these tools, we have monitoring processes in place so that we are able to know whether we are improving or not. And then in addition to the monitoring, feedback becomes very key. We monitor and then we give feedback to the teams. And lastly, the other bit we are recommending is making sure we are able to do root cause analysis every time you get an incident. Ensure we have root cause analysis just to be able to reach to the root cause to find out what exactly led to this. And in the root cause analysis, it's important that we involve all the teams which were involved in that process. And the other thing we recommend incorporating in the root cause analysis process is a just culture process. And this ensures that we are just in the way we are handling the incident, so that again, our staff don't reach to an extent where they feel that we are victimizing them. Thank you so much. That's the end of our presentation.